Ever stop to think about these amazing workhorses inside you, constantly filtering, constantly cleaning, and you don't even have to think about it? Today, we're diving deep into one of the most vital systems doing just that, the renal system.
Absolutely. Those kidneys, they're true masters of purification. And
Well,
keeping them healthy is just fundamental for, well, everything else.
it really is. When you think about what keeps us ticking, kidney function is way up there.
hmm They're involved in so many critical jobs that if things go sideways here, it affects the whole body. Seriously.
Exactly. And because you asked for it, we're doing a deep dive based on the renal system chapter from the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition. So, our mission today, pull out the essential knowledge. Anatomy, how it works, diagnostics, common problems, how we manage them.
And hopefully present it in a way that's clear, maybe even a bit engaging.
That's the plan. We want you to really get why this system's so crucial.
Yeah, it's a hefty topic, no doubt about it. But we'll break it down. Digestible insights, that's the goal. Memorable takeaways.
Okay, let's jump right in. Foundations first. Kidney anatomy. So picture this. You've got two of them, right?
Two kidneys, yeah. Nestled back there against the abdominal wall, sort of on either side of your spine, around your lower ribs.
And they've got this tough outer layer, the renal capsule.
That's it. Protects them. And if you were to look inside, you'd see two main zones.
Right, the cortex and the medulla.
Exactly. The outer part's the cortex. That's where you find the glomeruli, those initial filters. Then deeper in, you have the medulla, shaped like pyramids full of tubules.
And all that working tissue together, cortex, medulla, pyramids, that's the parenchyma.
You got it, the functional stuff. And the real stars within that parenchyma are the nephrons. Millions of them in each kidney.
The functional units,
Yeah.
each one with a glomerulus and this whole network of tubules.
And their job is just incredibly precise. They pull back what the body needs, ditch what it doesn't, constantly tweaking the balance of fluids, waste, electrolytes, acids, and bases too.
Okay, let's zoom in on that glomerulus. It's like a tiny knot of capillaries, right? The first self-filter station.
Yeah, like a super efficient little strainer.
Yeah.
Blood comes in through the afferent arteriole, gets filtered, and leaves through the efferent arteriole.
And what gets filtered out is key.
Absolutely. It's very selective. Water, small stuff like electrolytes, glucose, amino acids, waste that all passes through. But the big things, large proteins, blood cells, they stay behind in the blood. Crucial distinction.
And that filtered fluid, the filtrate, gets caught by Bowman's capsule.
Yep. This little cup-like structure surrounding the glomerulus catches all that filtrate.
So electrolytes, glucose, amino acids, metabolic waste, all collected there. And then it heads straight into the tubules. First stop, the PCT.
Proximal convoluted tubule, yeah.
Yeah.
PCT. And this is where the kidneys start reclaiming the good stuff. Water, electrolytes, the body's actively pulling them back. Some passive movement too, but a lot of active transport requiring energy.
First pass at recovery. Then it flows into that hairpin turn, the loop of Henle, descending and ascending limbs.
Right. The descending loop is mainly about water reabsorption. Passive.
Mhm.
Water just follows the concentration gradient out.
Mm.
Then the ascending loop. That's where sodium and chloride get reabsorbed, mostly passively. And this loop is really critical for setting up the kidney's ability to concentrate urine later on, establishes that medullary gradient.
Got it. Sets the stage. After the loop, it's the DCT, the distal convoluted tubule. More reabsorption.
Yep, still pulling back sodium and water, both actively and passively. And the DCT is interesting because it's a major target for hormones, like aldosterone, which fine-tunes sodium balance and blood pressure. We'll definitely circle back to that.
Okay, so the fluid's been through the PCT, the loop, the DCT, constantly being modified. What's the final leg of the journey inside the nephron?
Well, by the time the fluid gets through the DCT and enters the collecting ducts, it's basically urine. It's
Right.
carrying the waste products we need to get rid of.
And the collecting ducts gather urine from many nephrons.
Exactly. They funnel it down into the renal pelvis, that central collecting area in the kidney. From the renal pelvis, it flows out through the ureters, one tube from each kidney.
Down to the bladder for storage.
Yep, the bladder. Temporary holding tank until it's time to void.
So that's the plumbing, essentially. But the kidneys do so much more than just make urine. Let's talk functions.
Oh, absolutely.
Hmm.
Huge functions. First off, acid-base balance. They work with buffers to keep blood pH right in that narrow sweet spot.
Mhm.
Critical.
And waste excretion, obviously. Urea, creatinines,
Mhm.
the byproducts of metabolism.
Right. Primary way we get rid of that stuff. Plus, Fluid and electrolyte balance, managing sodium, potassium, water levels.
Yeah.
Hugely important.
They're detoxifiers too, right? Filtering out toxins, drugs, drug metabolites.
Definitely. Anything water-soluble that needs to go. And don't forget the endocrine functions. They're hormone factories, too.
Ah, yes. Renin.
Renin, yeah, for blood pressure regulation via that whole RAAS system. And erythropoietin, EPO, tells the bone marrow to make red blood cells.
So important for preventing anemia.
And they synthesize active vitamin D, which you need for calcium absorption, bone health.
Yeah.
It's amazing how interconnected it all is.
It really is. Such complex little organs. Now, urine production itself, it's not just filtering, it's selective, right?
Precisely. It's selective reabsorption and secretion. As that filtrate moves through the tubules, the body pulls back almost all the water, electrolytes, glucose, whatever it needs.
Reclaiming the valuables.
Exactly. And at the same time, it actively secretes other things into the tubules, extra creatinine, hydrogen ions to manage pH, potassium if levels are high, pushing out the trash.
So what's left after all that pulling back and pushing out is urine.
That's it. Whatever wasn't reabsorbed or was actively secreted.
Okay, let's focus on water balance. Super critical. ADH is the key player here, antidiuretic hormone.
Yes, ADH is the main regulator. Produced up in the hypothalamus, released from the posterior pituitary in the brain. It's basically the body's signal to the kidneys.
Yeah.
Conserve water.
And what triggers that signal? When does the body say, hold on to water?
Few key things. Dehydration, obviously, if your overall body water is low. Also, if your blood sodium concentration gets too high, signals water is relatively scarce. And low blood volume. If you lose blood or fluids, the body wants to conserve what's left. ADH gets released.
So ADH is circulating. What does it actually do at the kidney level?
It targets the DCT and, even more so, the collecting ducts. It basically makes the walls of those tubules more permeable to water. Opens up the water channels, the aquaporins.
Ah, so water can leave the tubule more easily.
Exactly. Osmosis pulls water out of the filtrate back into the bloodstream. Result: less urine produced, and the urine that is produced is more concentrated. Body holds on to water.
And if there's no ADH or not enough...
Then you get the opposite. The tubules stay less permeable to water, lots of water stays in the filtrate, and you produce large volumes of very dilute urine. That's what happens in diabetes insipidus, a major water loss issue.
Makes perfect sense. Okay, what about sodium? Huge role in fluid balance, blood pressure. How do the kidneys manage sodium?
It's a delicate dance. If your blood sodium goes up, your body tends to hold on to water to balance it out. That increases your blood volume, which increases your blood pressure. But the body fights back. Higher blood pressure actually increases the GFR, the filtration rate in the kidneys. More filtering means more sodium and water get pushed out in the urine, which brings blood volume and pressure back down. It's a feedback loop.
And the RAAS system, renin-angiotensin-aldosterone, that's the big hormonal controller for sodium, isn't it?
Absolutely central, especially for sodium reabsorption in the DCT. It kicks off when the kidney senses low blood pressure or low sodium concentration in the DCT fluid.
So low pressure or low sodium triggers renin release.
Yep. Renin converts angiotensin from the liver into angiotensin first. Then ACE enzyme, mostly in the lungs, converts angiotensin I into angiotensin II.
And angiotensin II is the real powerhouse.
It is. It's a potent vasoconstrictor, squeezes blood vessels to raise pressure directly, but it also tells the adrenal glands, sitting on top of the kidneys, to release aldosterone.
Okay, so angiotensin II triggers aldosterone. What does aldosterone do?
Aldosterone acts on the DCT. It tells the kidney cells there to reabsorb more sodium back into the blood, and water follows sodium, so blood volume increases.
Ah, raising blood pressure that way too.
Exactly. Aldosterone also promotes potassium secretion into the urine. So the net effect is, hold sodium in water, get rid of potassium. This raises blood volume and pressure, which then shuts off the initial renin release. Another feedback loop.
Wow, very intricate. So aldosterone helps get rid of potassium too? Is that the main way potassium is regulated?
It's a major way. High serum potassium itself also directly stimulates aldosterone release from the adrenals.
Oh, interesting. So high potassium triggers aldosterone, which then tells the kidneys to secrete more potassium into the urine.
Precisely. Brings the potassium level back down.
Okay, one more big balancing act. Acid base, or pH. How do kidneys keep that stable?
They work alongside blood buffers and the lungs. The main blood buffer is the bicarbonate carbonic acid system.
Lungs handle the carbonic acid part by blowing off CO2.
Right. Respiratory control. The kidneys handle the bicarbonate part. They can reabsorb bicarbonate back into the blood if things are too acidic, or excrete it if things are too alkaline.
And they need to maintain that specific 20-to-1 ratio of bicarb to carbonic acid for the normal pH range, 7.35 to 7.45.
That's the magic ratio. When strong acids hit the blood, bicarbonate buffers them, forming carbonic acid. That carbonic acid breaks down into CO2 and water, and the lungs exhale the CO2.
So lungs get rid of the acid volatile component. What else do kidneys do for acid?
They can actively secrete hydrogen ions, acid, into the urine, usually in exchange for reabsorbing sodium. And they can produce ammonia, which binds with hydrogen ions to form ammonium, allowing more acid to be excreted without making the urine itself dangerously acidic. They can also excrete acid buffered by phosphate.
Very clever. Okay, brief mention, adrenal glands. Sitting on top of the kidneys, related function.
Definitely related. They produce aldosterone, as we said, which directly impacts kidney function, sodium, water retention, blood pressure, tightly linked.
Got it. Now, downstream, the bladder, the storage tank.
Yep. The bladder's wall is mostly smooth muscle, the detrusor muscle, stretches to hold urine, contracts to expel it.
And those one-way valves where the ureters enter, ureterovesical sphincters.
Crucial. Prevent urine from backing up into the kidneys, which would risk infection. Bladder holds maybe a liter max, but we usually void about 1,500 milliliters total per day.
And for men, the prostate gland sits right there too.
Right around the urethra as it leaves the bladder. Produces seminal fluid, but if it gets enlarged, it can obstruct urine flow. Big issue in BPH.
Okay. Before we hit diagnostics, the chapter lists risk factors for renal problems. What should people be aware of?
Quite a few things. Exposure to nephrotoxins chemicals, certain meds, contact sports, risk of trauma, diabetes and high blood pressure are huge ones.
Family history.
A family history of kidney disease, recurrent UTIs, heart failure because it affects kidney perfusion, high sodium diets, polycystic kidney disease, kidney stones, basically anything that strains, damages, or obstructs the kidneys or urinary tract.
Good overview. Okay, let's switch gears. How do we figure out how well the kidneys are actually working? Diagnostic tests.
All right, Chapter 10 has the normal values, but let's talk key tests. Serum creatinine is fundamental.
Creatinine, byproduct of muscle metabolism.
Exactly. Filtered by the kidneys. So if your blood creatinine level is high, it generally means your kidneys aren't filtering well. Your GFR is likely down.
But it only goes up after significant damage, right?
That's a key point.
Yeah.
You often need to lose about 50% of kidney function before creatinine starts climbing noticeably. So it's not an early detector of mild damage.
Okay. Then there's BUN, blood urea nitrogen.
Urea is a waste product from protein metabolism in the liver. Kidneys clear it. So BUN also reflects kidney clearance.
But BUN can be affected by other things, too.
Yes, that's the tricky part.
Yeah.
Dehydration, high protein intake, infection, stress, steroids, GI bleeds, muscle breakdown. Lots of things can raise BUN, even if the kidneys are okay.
So how do you sort that out?
You look at the BUN to creatinine ratio. If both are up but the ratio is normal, it might be something non-renal like dehydration. If creatinine is disproportionately high or the ratio changes, that points more towards kidney dysfunction.
And the GFR test itself, glomerular filtration rate.
That's the gold standard measure, really. It estimates how much blood your glomeruli are filtering per minute, a direct look at function.
Okay, let's talk urine tests. Urinalysis is super common. What can it tell us?
A ton. It's a basic evaluation. You look at color, clarity, specific gravity, pH, check for protein, glucose, ketones, blood cells, bacteria, casts.
How do you get a good sample?
Clean catch is best. First morning void is ideal, more concentrated. Clean the area first, collect midstream into a sterile cup. Need about 10-15 millimolar.
And refrigeration affects specific gravity. Need to note menstruation.
Yep. Refrigeration can falsely raise specific gravity, and menstruation can put red blood cells in the sample, so the lab needs to know.
Sometimes a single sample isn't enough, the 24-hour urine collection. Sounds like a hassle.
It requires careful instruction. Need to check about diet or med restrictions first, then the process. Start time, void, and discard the first one.
Okay, discard the first one.
Then collect every single drop for the next 24 hours in the special container, keeping it cold ice or fridge. Maybe a preservative in the jug.
And at the end time.
Void one last time. Add that to the collection. Precision is key for accuracy.
Specific gravity again, what does that really measure?
The kidney's ability to concentrate urine, how dense it is compared to water. Higher means more concentrated, maybe dehydration or high ADH. Lower means dilute, maybe high fluid intake or kidney damage where it can't concentrate.
Measured with a dipstick usually. Or refractometer.
Dipstick is common bedside. Refractometer in the lab is more accurate. Things like contrast dye, glucose, protein can interfere. Cold samples read falsely high. Normal range is wide, like 1.003 to 1.030.
Okay. If infection suspected, Urine culture and sensitivity.
Culture identifies the bug. Sensitivity tells you which antibiotics work. Again, clean catch midstream is crucial. Sterile container.
Need to clean the area really well first.
Yes, with bacteriostatic solution. Avoid contaminating the sample hands, skin, whatever. Send it to the lab ASAP. If the urine is super dilute from drinking tons of water, you might get a false negative, even if infection's there.
Creatinine clearance test, back to creatinine, but different.
Yeah, this measures how well the kidneys remove creatinine from the blood over time. It gives a good estimate of GFR.
Requires blood samples and timed urine, usually 24 hours.
Correct. Blood draw at the start and end, plus that carefully collected 24-hour urine. Encouraging fluids is good. Avoid caffeine maybe. Check about meds that might interfere.
And the collection is the same drill. Discard first, collect all, keep cold, void at the end.
Exactly. Normal is around 125 millimN for a young adult. Decreases with age. It's considered a better GFR estimate than just serum creatinine alone.
Okay, shifting to imaging, KUB.
Kidneys, ureters, bladder x-ray. Simple abdominal film. Good for seeing some kidney stones or maybe signs of bowel obstruction. No special prep usually.
Bladder scan, that's ultrasound, right?
Yep. Bladder ultrasonography. Non-invasive. Uses sound waves to measure how much urine is in the bladder. Useful for checking retention, residual volume after voiding. Quick, painless.
IVP intravenous pyelogram or urography. Sounds more involved. Contrast dye.
Yes, IV contrast dye is injected. Then x-rays are taken as the dye moves through the kidneys, ureters, bladder. Shows structure and function, blockages, tumors.
Prep is important here. Allergies.
Crucial. Need consent. Ask specifically about iodine, seafood, previous dye allergies. Contraindicated in pregnancy. Caution with asthma, heart disease, kidney problems, usually NPO, maybe laxatives.
And tell the patient what to expect. Flushing, metallic taste.
Warm feelings, salty taste, normal sensations.
Post-procedure care for IVP.
Monitor vitals. Push fluids, lots of fluids, like a liter or more if allowed to flush the dye out. Check the IV site. Monitor urine output. Watch for delayed allergic reactions.
And the dye itself can be risky for the kidneys, nephrotoxic.
Yes, especially in older adults, dehydrated patients, or those with existing kidney issues. Always check baseline BU and creatinine before an IVP. Might need precautions.
Okay. Renography or kidney scan. Radioactive isotope.
Yep. Small amount injected IV. Camera tracks how the kidneys take it up and excrete it. Shows blood flow, GFR, tubular function.
Rep. Restriction.
Consent. Check allergies again. Usually no diet or activity restrictions.
Yeah.
Need to lie still. Might need images at different times. Push fluids after to clear the isotope. It's gone in about 24 hours.
Yeah.
Standard precautions for body fluids if incontinent.
Cystoscopy looking directly inside the bladder.
Right. Thin scope with camera up the urethra into the bladder. Look for inflammation, stones, tumors.
Yeah.
Could take a biopsy if needed.
Prep for cystoscopy, MPO if biopsy.
Yep, MPO if biopsy planned. If just cystoscopy, usually no special prep, just push fluids after.
Post-biopsy care.
Monitor vitals. Push fluids. Monitor IO and urine characteristics. Deep breathing for spasms. Pain meds, maybe sitz baths. Expect some burning, frequency. Pink urine initially that's normal, resolves in days.
But report bright red blood, clots, fever.
Absolutely. Signs of significant bleeding or infection. Need to notify the RN or provider.
Last one. Renal biopsy. Needle into the kidney.
Yes, percutaneous usually. Get a tissue sample for diagnosis. Check baseline coags, first vital, consent, MPO. Patient lies prone during.
Post-renal biopsy care sounds critical. Bleeding risk.
Huge concern. Frequent vitals, watch for low BP, high heart rate. Pressure on the site for maybe 30 months. Monitor H&H. Strict bed rest. Supine with a back roll for several hours. 2-6 usually.
Check the site and under the patient for bleeding.
Yes. Encourage fluids, 1.52 liters. Watch urine for blood. No heavy lifting for about 2 weeks. Report fever or hematuria after the first 24 hours.
That's a thorough look at diagnostics. Okay, let's move into kidney disorders, starting with acute kidney injury, AKI. What's the key feature?
Rapid loss of function. Happens quickly. Hours to days. Damage to kidney cells. The key is it's often reversible if you catch and treat the cause.
Unlike chronic disease, what causes AKI? 3 categories.
Yep. Pre-renal, intrarenal, postrenal. Pre-renal is anything reducing blood flow to the kidneys. Think volume depletion, dehydration, low cardiac output, shock, renal artery stenosis.
Intrarenal, damage within the kidney.
Exactly. Direct damage to the kidney tissue. Most common is acute tubular necrosis,
Yeah.
UTN. Can be from prolonged lack of blood flow, ischemia, or toxins.
Nephrotoxins, like what?
Oh, lots. Certain antibiotics like aminoglycosides, vancomycin, NSAIDs, contrast dye, heavy metals, solvents, even myoglobin from muscle breakdown. Also, infections or inflammation right in the kidney.
And postrenal, after the kidney.
Obstruction. Anything blocking urine flow out of the kidneys. Bladder, neck obstruction, like BPH.
Yeah.
Tumors, stones in the ureters, infections causing swelling. Urine backs up, damages the kidneys.
AKI goes through phases, right? Onset.
Onset starts with the event, then often the oliguric phase. Urine output drops suddenly, less than 400 ml a day. This phase lasts maybe 8-15 days. Longer it lasts, the poorer the prognosis.
What do you see in the oliguric phase? Fluid overload.
Definitely. Hypertension, edema, maybe effusions, heart failure signs, pulmonary edema. Also, uremia kicks in, waste products build up.
Wow.
Anorexia, nausea, vomiting, itching.
Metabolic acidosis. Neurological changes.
Yep. Acidosis, maybe small breathing. Neuro changes from tingling to drowsiness, even coma. Pericarditis is possible too.
Labs in oliguric phase. High BU and creatinine, high potassium.
Elevated BU and creatinine, low GFR. Hyperkalemia is a big danger. Sodium might be low or normal due to dilution. Hypocalcemia, hyperphosphatemia. Urine-specific gravity might be low, prerenal or normal. Intrarenal damage.
Interventions here. Fluid challenge early. Then restriction. Diuretics.
Maybe a careful fluid challenge initially. But if overloaded, definitely fluid restriction. Maybe diuretics like furosemide if they still respond.
Okay, then the diuretic phase. Kidneys starting to wake up.
Sort of. Urine output starts increasing, sometimes dramatically 4 to 5 liters a day. Nephrons are clearing waste better, but they still can't concentrate urine properly.
So risk of dehydration now.
Exactly. Dehydration, hypovolemia, hypotension, tachycardia are risks. LOC usually improves, though. Labs show BU and creatinine starting to fall, but GFR is still low, improving slowly. Big electrolyte losses here, hypokalemia, hyponatremia, might need IV fluids with electrolytes.
And finally, the recovery phase.
Slow process. Can take 1-2 years for full recovery if it happens. Urine volume normalizes, strength improves. Older adults might not fully recover. GFR increases. BU and creatinine head towards normal. Some people progress to CKD from here.
Nursing care for AKI covers all phases then. Vitals, strict IO.
Absolutely. Hourly IO and oliguric phase. Daily weight gain suggests fluid retention. Monitor labs, constantly BU and creatinine, electrolytes, acidosis. Check LOC, signs of infection, which might be masked. Lung sounds, edema.
Diet, meds.
Diet usually low, moderate protein, high carb. Restrict potassium, sodium based on labs. Be super careful with meds, check doses, avoid nephrotoxins. Prepare for possible dialysis like CRT if they're unstable. And lots of emotional support.
Okay, let's contrast that with chronic kidney disease, CKD. Slow, progressive, irreversible.
That's the key difference. GFR, 60 millilin for 3 months or more. It happens in stages. Often no symptoms until 75% function is gone. Uremia and ESKD, end-stage kidney disease, occur around 90-95% loss.
And fluid balance can go either way in CKD, hyper or hypovolemia.
Yeah. Early on, maybe okay. Later, often inability to excrete sodium water leads to hypervolemia. But sometimes inability to conserve sodium water leads to hypovolemia. It affects basically every body system. Dialysis or transplant eventually needed for ESKD.
Main causes of CKD, diabetes and hypertension again.
Those are the big two. Can also follow AKI or result from chronic obstruction, recurrent infections, autoimmune disorders, renal artery occlusion.
Assessment sounds like it needs to be head to toe.
Does. Box 51-4 lists it all. Neuro, cardio, respiratory, hematologic, GI, urinary, skin, musculoskeletal, reproductive changes. Plus, huge psychological impact, anxiety, depression, body image issues, denial.
Interventions overlap with AKI, but long-term focus. Diet is key.
Yes, similar monitoring. Diet is crucial, moderate protein, high carb, low potassium phosphorus usually. Oral care for stomatitis. Skin care for itching, pruritus. Lots of education on restrictions, daily weights. Support coping, preparing for dialysis transplant decisions. Lifestyle choices.
Let's hit some of those specific CKD problems. Activity intolerance, insomnia.
From anemia, waste buildup. Need rest periods, plan activities, maybe cautious use of CNS depressants for sleep.
Anemia due to low EPO.
Primarily. Monitor H&H. Give ESAs like epoetin alpha, folic acid, iron supplements, careful with phosphate binders, constipation. Maybe IV iron. Transfusions only if really necessary. Suppress EPO stimulus. Risk antibodies for transplant.
GI bleeding risk.
Urea breaks down to ammonia, irritates mucosa. Monitor H&H, stool, occult blood. Avoid aspirin, SAIDs, kidney excretion issues, bleeding risk.
Hyperkalemia. Still a major danger.
Huge danger. Monitor EKG, apical rate for dysrhythmias, serum K+ levels, low K+ diet. Meds like sodium polystyrene sulfonate, Kyaxolate. Maybe IV dextrosensilin, calcium gluconate, sodium bicarb. Loop diuretics if some function remains. Avoid K plus knee-sparing diuretics. Dialysis is severe. Continuous cardiac monitoring is key.
Hypermagnesemia, hyperphosphatemia.
Hypermagnesemia, because kidneys can't excrete Mg plus K. Monitor cardiac, CNS, or muscular signs. Loop diuretics, maybe calcium. Avoid Mg plus A-containing meds, antacid laxatives. Hyperphosphatemia is common. Low-risk calcium stimulates PTH. Bone problems. Need phosphate binders with meals. Cause constipation. Need stool softeners. Limit high phosphorus foods.
Hypertension and hypervolemia almost expected.
Yes. Monitor BP, fluid sodium restriction, diuretics, antihypertensives for HDN. For hypervolemia, monitor BP, IO, daily weight edema. Watch for HF and pulmonary edema signs. Report STAT. Fluid restriction, low sodium diet. Avoid OTC meds without checking.
Hypocalcemia.
Hypovolemia. Hypocalcemia from high phosphate and lack of active vitamin D. Monitor calcium, give supplements activated with D. Hypervolemia can happen too. Monitor for low BP, high HR, low output, dehydration. Replace fluids based on electrolytes.
Infection risk is high.
Suppressed immunity, dialysis access, malnutrition. Monitor for signs. Avoid catheters if possible. Strict asepsis. Avoid sick contacts, fatigue. Use antibiotics carefully. Watch for nephrotoxicity.
Metabolic acidosis.
Kidneys can excrete H+ or make bicarb. Give alkalizers like sodium bicarb. Patients often adapt to lower levels, though.
And briefly, muscle cramps, neuro changes, ocular issues, injury risk, pruritus.
Cramps from electrolytes, uremia, treat imbalances.
Yeah.
Heat massage. Neuro changes from waist fluid monitor, LOC, confusion, restless legs, ocular irritation from calcium deposits, control KFOS, eye drops, injury risk from weak bones, safety measures, pruritus from urate crystals, meticulous skin care, avoid soaps, antihistamines, trim nails.
And huge psychosocial needs.
Absolutely. Listen, allow grieving, involve family, educate on options, support groups, support decisions, including potentially no treatment end-of-life care in elderly.
Okay, uremic syndrome, that's basically severe CKD symptoms.
Yeah, the cluster of sign symptoms when waste products really build up due to severe ESKD affects everything.
Symes, oliguria, high wastes in blood, electrolyte chaos, altered LOC, GI issues.
All of that. Hypertension or hypotension, stomatitis, nausea, vomiting, diarrhea, constipation.
Interventions, monitor vitals, electrolytes, IO, strict diet.
Limited high-quality protein, limit sodium, nitrogen, potassium, phosphate, lots of supportive care. Help coping with body image changes, often leads to dialysis.
Right. Let's talk hemodialysis, HD. Cleanses the blood outside the body.
Uses a dialyzer artificial kidney with a semi-permeable membrane. Blood on one side, dialysate fluid on the other.
What does it achieve?
Removes waste, urea, creatinine. Removes excess fluid. Restores buffers and electrolyte balance.
How? Diffusion, osmosis, ultrafiltration.
Diffusion moves solutes, waste, from high concentration blood to low dialysate. Osmosis moves fluid towards higher soot concentration. Can adjust dialysate. Ultrafiltration uses pressure gradient to push extra fluid out.
The dialysate fluid, water, and electrolytes.
Specially treated water, plus electrolytes tailored to the patient. Bicarbonate buffer. Not sterile, but water meets high standards. Bacteria can't cross the membrane.
Nursing care during HD. Vitals, labs, weight, access.
Monitor vitals. Constantly temp might rise slightly. Big rise needs check for sepsis. Labs before after, BUN, CR, CBC. Way before after to check fluid removal. Assess access patency. Watch for bleeding, heparin used. Monitor for hypovolemia shock. Ensure nutrition.
Withhold BP meds before and meds cleared by dialysis.
Yes, hold antihypertensives usually. And meds like water-soluble vitamins, antibiotics, digoxin might need dose timing adjusted around dialysis.
Access is key for HD. Temporary catheters, subclavian, femoral.
Short term. AKI, waiting for fistulograph to mature. Access failure. Monitor site closely for infection, bleeding, dislodgement. Only use for dialysis. Keep dressing occlusive. Usually heparin lock, aspirate before use. Femoral has higher infection risk, limits mobility.
External AV shunt, cannulas connected outside.
Older tech, riskier. Immediate use, no needles, but high risk of disconnection, hemorrhage, infection, clotting, skin erosion. Keep dry. Clamps at bedside, always. No BPIV draws on that arm. Check breathral absence means clot. Report STAT.
Internal AV fistula, the preferred long-term option.
Yes. Surgically connect artery and vein in the arm. Vein matures or enlarges over 4 to 6 weeks with exercise. Ball squeezing. Then you stick needles into the mature vein for dialysis.
Advantages. Lower clotting infection. Long-term use.
All true. No external parts after healing, but can't use immediately. Requires needles. Risks. Infiltration, aneurysm, rare HF, arterial steal syndrome, and ischemia.
Internal AV graft artificial vessel.
Use if veins aren't good for fistula. Gore-Tex or bovine graft connects artery and vein. Can use sooner, maybe 2 weeks, but higher clot infection risk than fistula.
Nursing for fistulous grafts. Protect the arm.
Absolutely. NOBP, IVs, blood draws on the access arm. Teach patient. Check pulses below access. Monitor for swelling, coolness, Steele syndrome. Check Thrillbrute daily report absence immediately. Monitor for infection, HF signs.
Complications of HD itself. Box 51-5 lists several.
Air embolus, disequilibrium syndrome, electrolyte shifts, encephalopathy, hemorrhage, hepatitis risk, lower now, hypotension, sepsis, shock.
If complications occur, slow stop dialysis, notify provider immediately.
Yes. One nurse stays with patient, monitors, another gets orders.
Air embolism priority action.
Stop dialysis. Position patient left side, Trendelenburg, head down. Notify team stat. Give oxygen. Monitor vitals O2 sat. Document everything. Signs. Sudden shortness of breath, chest pain, low BP, low O2, cyanosis, anxiety, confusion.
Okay, let's switch to peritoneal dialysis, PD. Uses the peritoneum.
Exactly. The lining of the abdomen acts as the semi-permeable membrane. Dialysate fluid is infused into the peritoneal cavity via a PD catheter. Exchange happens across the peritoneal capillaries.
Contraindications, peritonitis, recent abdominal surgery.
Yes, active peritonitis, recent surgery, abdominal adhesions, sometimes severe diverticulosis.
Excess, tank off catheter.
Soft silicone catheter surgically placed into the peritoneal cavity, tunneled under skin. Has Dacron cuffs to anchor and prevent infection tracking. Sterile dressing at exit site, change daily when soiled. Takes 1 to 2 weeks for cuffs to seal well.
Dialysate for PD, sterile, glucose-based.
It is sterile, unlike HD dialysate. Glucose concentration determines fluid removal. Higher glucose pulls more fluid. Electrolytes adjusted, maybe heparin, maybe antibiotics, maybe insulin for diabetics.
The PD exchange, fill, dwell, drain.
Fill, fluid flows in by gravity, 10-20 minutes. Dwell, fluid sits in peritoneum. Exchange occurs 20 minutes to 8+ hours, depends on type prescription. Drain, fluid flows out by gravity, 15-30 minutes. That's one exchange.
Nursing care before, during PD.
Before. Vitals, wait, have patient void if possible. Check electrolytes, glucose. Assess catheter-sided dressing. During. Monitor vitals, respiratory status, pain. Watch dwell time. Don't extend hyperglycemia. Initiate outflow. Check characteristics, color, clarity. Accurate I.O. is critical.
Outflow less than inflow means retained fluid. More outflow or cloudy bloody needs reporting.
Exactly. Report any abnormal outflow, cloudy, bloody after initial exchanges, brown, urine-colored, or insufficient outflow.
Types of PD, CAPD versus ATD.
CAPD, continuous ambulatory PD, is manual, done by patient 247, usually 4 exchanges a day, including overnight dwell. APD, automated PD, uses a machine, cycler, often overnight while sleeping, automates the exchanges.
Big complication of PD is infection, peritonitis.
Huge risk. Watch for fever, cloudy outflow, key sign, rebound tenderness, abdominal pain, malaise, NV. Need outflow culture, antibiotics. Strict sterile technique is paramount for all connections and catheter care. Keep dressing dry.
Other PD issues, abdominal pain.
Common initially, usually fades. Warming dialysate helps. Abnormal outflow characteristics can indicate problems like perforation.
Insufficient outflow causes.
Constipation. Need fiber stool softeners. Catheter migration. Need x-ray. Drainage bag too high. Kinks. Fibrin clots may need milking. Changing position can help. Leakage around site possible initially.
Brief mention, CRRT continuous renal replacement therapy.
Slower, continuous dialysis, 8/24 Thursday. For critically ill AKI patients, often unstable for rapid shifts of HD. Gentler fluid solute removal via hemofilter.
Okay, final major topic, kidney transplantation. Implanting a donor kidney for ESKD.
Requires compatible donor, lifelong immunosuppressants for recipient.
Donors, living, related, unrelated, deceased NHBD cadaver.
Yep. Living related, often best match. NHBD, a long heart-beating donor, circulatory death. Cadaver, brain death donor, kept on vent.
Donor criteria, healthy, good kidney function, screened extensively.
Must be healthy, no systemic disease, cancer, infection, kidney disease, HTN. Rigorous screening, ABO, HLA tissue typing, psych-evil for living donors. Laparoscopic removal common for living donors now.
Pre-op care for recipient, matching tests, immunosuppressants started, dialysis beforehand.
Histocompatibility tests crucial. Start immunosuppressants. Strict asepsis. Verify recent dialysis within 24 hours. Ensure no active infection. Psych support for all involved.
Post-op recipient care. Kidney placed in iliac fossa. Monitor urine output hourly.
Yes, usually lower abdomen. Urine output, immediate living donor or delayed, deceased. Might need HD temporarily. Monitor vitals closely for rejection complications. Hourly urine output, crucial report, 100 mLAIR stat. Manage 4 fluids carefully based on output. Daily weights, labs. Semi-Fowler's position.
Monitor catheter patency, urine color, remove catheter ASAP.
Yes, catheter usually stays 3 to 5 days. Urine initially pink bloody, clears gradually. Report gross hematuria clots. Remove catheter ASP to reduce infection risk. Aseptic technique vital. Infection major cause of death first year.
Monitor bowels, oral hygiene, cough, deep breathe, meds, ambulation.
All important. Diet advances as bowel function returns. Meds include antifungals, antibiotics, lifelong immunosuppressant steroids. Ambulate early. Monitor closely for rejection. Support coping. Body image. Post-transplant education is extensive. Box 51-6.
Graft rejection is the major complication. 3 types.
Hyperacute. Within 48 hours, need to remove kidney. Acute. Most common first week months. Often reversible with more immunosuppression. Chronic. Slow. Months, years. Mimic CKD. May need retransplant.
Signs of rejection: fever, graft pain, weight gain, edema, HTN, malaise, rising BUNCR.
Yes, and decreased creatinine clearance. High WBC. Ultrasound biopsy confirms.
Okay, quick run through common urinary disorders: cystitis, UTI, bladder inflammation, E. coli common, more in women.
Yes. E. coli frequent cause, women higher risk, shorter urethra, proximity to the rectum, sexually active pregnant women vulnerable.
Symptoms: frequency, urgency, burning, dysuria, maybe cloudy foul urine, hematuria, altered mental status, and elderly.
Symptoms. Elderly might just show confusion. Urinalysis shows WBCs.
Interventions: culture first, fluids, meds, acidic urine, prevention, education.
Get culture before antibiotics. Push fluids, 3L day, meds, analgesics, antibiotics. Maintain acidic urine, pH 5.5. Heat sits baths for comfort. Prevention is key. Hygiene, front to back. Void regularly. Cotton underwear. Void after intercourse. Avoid irritants.
Urosepsis, UTI spreading to bloodstream. Serious.
Very serious. Bacteremia from UTI, E. coli, common. Risk in immunocompromised catheters, untreated UTI can lead to septic shock. Fever, often earliest sign.
Treatment: culture, IV antibiotics until a febrile, then oral.
Exactly. Aggressive treatment needed.
Urethritis, inflammation of urethra. STIs common cause in men. Irritants in women.
Yep. Gonorrhea, chlamydia in men. Sprays, spermicides, UTIs in women.
Symptoms: burning, frequency, urgency, discharge men. Lower abdominal discomfort women.
Correct.
Interventions: fluids, STI testing, antibiotics. Avoid irritants, intercourse. Partner notification, treatment for STIs.
All crucial, especially partner treatment for STIs like chlamydia to prevent reinfection spread.
Ureteritis, ureter inflammation, often with pyelonephritis.
Yes, bacterial viral. Symptoms: dysuria, frequency, maybe discharge man. Treat underlying cause. Symptomatic relief. Specific meds for trichomonas, yeast, chlamydia if identified.
Pyelonephritis, kidney infection, pelvis merenchyma. Acute versus chronic.
Acute is sudden onset, often ascending infection, can lead to bacteremia chronic. Chronic is slow, progressive, from recurrent infections or obstruction reflux, leads to scarring, CKD, E. coli common.
Acute symptoms: fever, chills, nausea, flank pain, CVA tenderness, dysuria.
Yes, classic signs. Tachycardia, tachypnea too.
Chronic symptoms: more subtle. HTN, poor urine concentration, azotemia.
Often found incidentally. May have inability to conserve sodium, pyuria, proteinuria.
Interventions for pyelo: vitals, fluids, 3L, monitor IO in 1500 millirel, rest, diet, heat, meds, analgesics, antipyretics, antibiotics, follow-up culture.
All standard interventions. Monitor for kidney failure signs. Follow-up culture essential.
Skipping glomerulonephritis nephrotic syndrome, chapter 34, polycystic kidney disease, PKD, genetic, cysts destroy kidney tissue, leads to CKD.
Yes. Cysts form, enlarge, cause damage. No cure, progresses to ESKD. Infantile, recessive, severe, and adult, dominant, manifests 30-40s.
Adult PKD symptoms, often asymptomatic till later. Then flank abdominal pain, UTIs, hematuria, HTM, palpable kidneys.
Correct. Pain worsens with activity. Increased abdominal girth.
Management, supportive. Monitor hematuria, cyst rupture. Maybe increase NEA plus water. Pain control, avoid NSAIDs. Prevent constipation. Treat UTEs, HTN, dialysis, transplant prep. Genetic counseling.
Exactly. Focus on managing complications and preparing for eventual renal failure. Genetic counseling is very important.
Hydronephrosis, kidney swells due to urine backup, obstruction.
Distension of renal pelvicalysis from obstruction, stone, tumor, BPH. Pain might radiate to groin.
Interventions: monitor vitals, fluid electrolytes, SPbiology, dehydration, post-relief. Watch for diuresis. Prepare for nephrostomy surgery to fix obstruction.
Right. Treat the cause, manage fluid balance carefully.
Renal calculi, kidney stones, common, painful. Cause pain, obstruction, trauma, infection.
Whole of the above. Diagnosis via imaging, KUB, IVP, CT, US. Stone analysis after passage guides prevention. Hydroreader if stone blocks ureter. Untreated obstruction leads to damage hydronephrosis.
Causes: family history, diet, high K, Vit D, protein oxalate, purines, dehydration, UTIs, immobilization, hypercalcemia, gout.
Many contributing factors. Dehydration is a big one.
Symptoms: renal colic, severe flank pain radiating down, NV, pallor, sweating, frequency tension,
Hematuria.
classic presentation. Excruciating pain is hallmark.
Interventions. Pain management is key. Fluids, 3L. Heat. Meds, opioids, NSAIDs, strain all urine, ambulation, diet mods based on stone type, surgery prep if needed.
Pain control is priority. Fluids help passage. Strain urine to catch stone for analysis. Ambulation helps too. Diet changes for prevention later.
Stone treatments if needed. ESWL.
Extracorporeal shockwave lithotripsy. Non-invasive, uses shockwaves to break stone. Patient passes fragments. Push fluids after.
Percutaneous lithotripsy. Invasive. Goes through skin, nephroscopy, or urethra cystoscopy to reach stone. Break with ultrasound laser. May leave nephrostomy tube catheter. Push fluids after.
Open surgery, ureterolithotomy, pyelolithotomy, nephrolithotomy.
Less common now, but options if lithotripsy fails. Incisions to directly remove stone from ureter, renal pelvis, or kidney. Drains tubes, common post-op.
Nephrectomy if severe damage.
Partial or total removal of kidney if extensive damage, infection, tumor. Monitor drains, protect skin, encourage output. Don't irrigate tubes unless ordered.
Kidney tumors, benign or malignant, metastasis risk.
Can be either. Malignant can spread bone, lungs, liver, cause often unknown. Advanced signs, dull flank pain, palpable mass, painless gross hematuria.
Treatment: radical nephrectomy usually. Radiation, chemo maybe.
Surgery is main treatment. Remove kidney, adrenal, surrounding tissue. Monitor closely post-op for bleeding, adrenal insufficiency. Manage fluids output. No nephrostomy tube irrigation unless by RN.
Epididymitis, inflammation of epididymis. Causes: UTI, STI, prostatitis.
Yes. Infection travels up urethral ducts.
Yes. Symptoms: scrotal groin pain, swelling, post in urine, fever chills.
Typical signs can lead to abscess.
Interventions: fluids, bed rest, scrotal elevation, cold compresses, antibiotics, patient partner if STI. Avoid straining sex until resolved.
Standard care. Partner treatment essential for STIs. Prevent recurrence.
Prostatitis, prostate inflammation, bacterial versus abacterial.
Bacterial from infection.
Yeah.
Bacterial may be viral, other causes.
Bacterial symptoms: acute illness, fever, urinary symptoms, perineal pain, tender prostate.
Yes, plus discharge, WBCs, and prostatic secretions.
Abacterial symptoms: backache, dysuria, perineal pain, frequency, hematuria, maybe enlarged tender prostate.
Correct. Often less acute presentation.
Interventions: fluids, sitz baths, meds, antibiotics for bacterial, analgesics, stool softeners, activities to drain prostate, intercourse massage. Avoid irritants, prolonged sitting, acute.
Tailored to type. Antibiotics only for bacterial. Supportive care for both.
Benign prostatic hypertrophy, BPH, prostate enlargement compressing urethra, common 50.
Very common. Slow enlargement obstructs urine flow.
Symptoms: early, weak stream, urgency frequency, nocturia, late, hesitancy, incomplete emptying, dribbling, retention, UTIs.
Classic progression of obstructive symptoms.
Interventions: fluids, catheter if retention, avoid certain meds, anticholinergics, etc. Meds to shrink relax prostate, diet changes, timed voiding, surgery prep.
Start conservative. Meds often help. Alpha blockers, 5-ARIs. Avoid bladder irritants. Surgery if severe.
CC41.
Bladder cancer, C41. Bladder trauma, blunt or penetrating injury. Pelvic fracture risk.
Yes. Lower abdomen injury, pelvic fracture can puncture bladder.
Symptoms: anuria, hematuria, pain below umbilicus, maybe radiates to shoulder. Envy.
Key signs:
Interventions: vitals, monitor bleeding shock, bed rest. End no catheter if blood at meatus until urethrogram. Prep for suprapubic cath surgery.
Crucial point about the catheter. Need to rule out urethral injury first, then manage based on injury severity.
Wow, okay, that was a lot. An incredibly detailed deep dive into the entire renal system. It really hammers home how vital these organs are. It really does. We covered, well, basically everything from the ground up. Anatomy, physiology, all those diagnostic tests.
Then AKI, CKD, the different types of dialysis, transplantation.
And wrapped up with a whole host of common disorders. Infections, stones, BPH, PKD. It's a complex but fascinating system.
And throughout all of it, the critical role of nursing assessment, intervention, and patient education just shines through, doesn't it?
Absolutely indispensable. Monitoring fluid balance, electrolytes, recognizing complications early, managing dialysis, supporting transplant patients. It's huge.
Remember that critical thinking scenario from the beginning? The AKI patient with lung crackles.
Right. And the answer, as the chapter points out, is to notify the RN and provider immediately. Those crackles signal potential fluid overload, pulmonary edema, maybe heart failure, needs urgent attention.
Good callback. And for you listening, remember, those practice questions in the Saunders chapter are great for reinforcing all this information.
Definitely use them. See what's stuck, what needs another look.
We really hope this deep dive gave you a solid understanding. Maybe pick an area that interested you and explore it even further based on your own learning goals.
Yeah, and just take a moment to appreciate your own kidneys. Tireless workers. And the medical advances allowing us to support them when they struggle are pretty amazing too. Reflects the resilience of the body and the dedication of healthcare folks.
Couldn't agree more. Thank you so much for joining us on this deep dive into the renal system. We hope it was insightful and valuable for you.